Good morning, everybody. Welcome back. Today, we'll talk about the fourth part of our lectures, ABG practical approach. Today, we'll talk about respiratory alkalosis step-by-step approach. First step, as you all of you know now, pH equal constant multiplied by bicarb over PCO2. So, in respiratory alkalosis, you will find low PCO2 and the high pH. What is the second step? Second step, you should ask yourself, is it acute or chronic? As the respiratory acidosis, but in the reverse direction. In acute pathology, like acute drop of PCO2 due to wash from the body has no time to wash out bicarb to try to minimize the change in pH. So, in acute disease, in acute things, the change in PCO2 will lead to marked change in the pH. There is formula for that change. In acute respiratory alkalosis, the pH increase from the normal will be equal the change of PCO2, which is 40 normal PCO2 minus the patient PCO2 in respiratory alkalosis multiplied by big value. So the increase in pH will be high because the change of PCO2 will be multiplied by big value. But in chronic respiratory alkalosis, the body has the time to wash out bicarb through the kidney, so will minimize the increase in pH. And the expected pH in the chronic respiratory alkalosis will be a change of PCO2, which is 40, minus elevation PCO2 multiplied by a small value, which is 0.2. Okay? Without formula, you should look for the PCO2 of the patient and the pH. If you find a marked increase in the pH, it is going with acute. If it is minimal increase, it's going with chronic. This is like respiratory acidosis, but in the reverse direction. What about the third step? Third step, please. If you find any respiratory alkalosis, you should look for the PO2. Because if hypoxic, this is the hypoxic, you should search about the hypoxic causes of respiratory alkalosis, which is acute cardiopulmonary pathology lead to hypoxia, like pulmonary embolism, pneumonia, acute pulmonary edema. So, in acute cardiopulmonary causes of hypoxia, the patient will be tachypneic. So, he will wash CO2 acutely. So, he will develop acute respiratory alkalosis. For any respiratory alkalosis, you should think about hypoxia. Third step, to get the causes of acute respiratory alkalosis and hypoxia. If not hypoxic, please look for these three diseases: acute hepatic failure, septicemia and septic shock, and central causes like brain infarction, hemorrhage, meningoencephalitis. This is very, very important because this is the common causes of respiratory alkalosis, and usually in ICU we'll see acute respiratory alkalosis. This is the common cause of acute respiratory alkalosis in the ICU. Hypoxic causes and non-hypoxic causes. Step 4, always look for another hidden metabolic acid-base balance. Is there any concomitant metabolic acid-base balance? So, as we said, in acute respiratory alkalosis, the body has no time to wash out bicarb, so you will expect bicarb to be decreased by 2 for every decrease of 10 of PCO2. But in chronic respiratory alkalosis, the body has a time to wash out bicarb, so it will wash the bicarb by decrease it by 5 for every 10 decrease in PCO2. It is similar to respiratory acidosis, but in the reverse direction. Let us see some practical cases. An 18-year male known case of sickle cell disease presented with left lower lobe pneumonia. Here is his X-ray. Here is the ABG. pH 7.51, BCO2 25, BO2 46, bicarb 22 on room air. What are you going to do with this ABG? First step, alkalosis, low CO2, it is respiratory alkalosis. Is it acute or chronic? You will see here there is big change of pH compared to the BCO2, and we can, by the formula, we can accurately know it. Okay, so it's going with acute respiratory alkalosis. Second step, is it hypoxic or non-hypoxic? Probably it is hypoxic respiratory alkalosis. Third step, is there any metabolic effect? The bicarb here expected to decrease. For every 10 will decrease by 2. I think it is going with acute and no other metabolic acidosis, because if you find bicarb too much decrease, that means it's accompanying metabolic acidosis. If it is increased, there is accompanying metabolic alkalosis. Let us explain by the formula. If acute, the change in the pH, the increase in pH will be high. So it will equal the change of the BCO2, 40, which is normal, minus the patient BCO2 multiplied by big value, will be this with the magnitude of change. So the pH will be 7.52. Okay, we'll add this to normal 7.4. If chronic, the increase in pH will not too much, will be equal the change in the BCO2 multiplied by a small value, which is this value. So the pH will be 7.43. Our patient pH is 7.5, going in the direction of the acute. The expected BCO2 in acute will be 23, which almost our patient bicarb. So this is acute respiratory alkalosis without accompanying metabolic acid-base balance, metabolic disorder. Usually, we used to treat this patient, sickle cell disease with pneumonia. We used to treat by antibiotic, exchange transfusion, because we fear about acute chest syndrome. We give steroids. Patient improved, but complain of vomiting, probably because steroid-induced gastritis. This is the ABG, next ABG of the patient, next day. pH 7.56, BCO2 28, BO2 160, bicarb 28 on 8 liter oxygen mask. What is the next step? Let us go step by step approach in this patient. pH is high, BCO2 is low, it is respiratory alkalosis. The magnitude of rise of pH is high compared to the decrease of BCO2, so it is going with acute respiratory alkalosis. And from the history, it is acute hypoxia going with acute respiratory alkalosis. And BO2 here, 160 on 8 liters, patient improved but still hypoxic. So there is hypoxic acute respiratory alkalosis. Third step, what is the expected bicarb in acute hypoxic respiratory alkalosis? We expect the bicarb to decrease by element of 2 for each 10 decrease of BCO2. But we see the bicarb here, it is increasing. So you don't need to do any formula in this situation, because we find an increasing bicarb, and the normal physiological response to respiratory alkalosis is to decrease the bicarb, but it's the magnitude of decrease which is different between acute and chronic. But to increase, it is unaccepted for the good physiology. So without any formula, you will say there is accompanied metabolic alkalosis in this patient. You remember, how can you go step-by-step approach in metabolic alkalosis? Yes, you are intelligent. You still remember the previous lectures. Okay, metabolic alkalosis, it is very easy. You know, more than 90% of the cases is due to diuretics intake, vomiting, gastrointestinal aspirations, and mineralocorticoid excess. Search in these causes in this patient. Our patient is taking steroid. Our patient has vomiting. Okay, So how can you differentiate between the steroid intake and the vomiting as a cause of metabolic alkalosis? Yes, you are intelligent. You are still remember the beauty urine chloride, which is differentiating factor in metabolic alkalosis. You will do urine chloride. If it's low, it's going with the vomiting. If it's high, it's going with the steroid intake. Yes, good. What else? A 45-year male patient admitted to ICU because of severe head trauma, connected to mechanical ventilator, SIMV mode, pressure support 15, respiratory rate 22, FiO2 50, B5, tidal volume 500. So the patient has the opportunity to get a spontaneous breath plus the ventilator breath. ICU medication, this patient has bad head trauma, we give furosemide, mannitol, ranitidine, phenytoin. Patient was always hyperventilating, sweating, febrile. And this is always the case of severe brain trauma. There is excessive catecholamine secretion, and there is what's called hyperventilation, sweating, tachycardia, hypertension, and sometimes the acute pulmonary, central pulmonary edema. This is the situation of our patient. He was in bad head trauma and severe sympathetic overactivity. This is a very bad CT, brain edema, epidural here, hematoma, subciliary hematoma, bad head trauma really. 1 week in ICU, all septic work was negative because the patient was febrile. His liver enzymes raised, ALT 440, AST 320, INR 1, which is normal. His ABG, pH 7.54, VO2 168, BCO2 25, bicarb 31. What are you going to do in this patient? Step-by-step approach, please. First, pH is high, BCO2 is low, it is respiratory alkalosis. The magnitude of rise is too much compared to the drop in the BCO2, that means it's acute respiratory alkalosis. Is it hypoxic or non-hypoxic? Probably because our patient has the opportunity to increase the respiratory rate, because ventilator can cause a change in the respiratory, can cause respiratory alkalosis, but our patient has spontaneous mood, SIMV, and can increase his respiratory rate. But really 168 over 50, you are talking about very mild hypoxia as an element. Probably there is another element of this respiratory alkalosis. What is other causes of respiratory alkalosis you know apart from hypoxic respiratory alkalosis? You remember the good three: acute hepatic failure, septicemia and septic shock, and brain insult. Intracranial causes of respiratory alkalosis: brain insult, meningoencephalitis, trauma, infarction, hemorrhage. This patient definitely has bad brain trauma and can cause hyperventilation. And at the same time, he has marked increase in the liver enzymes, which probably due to drug-induced, which is phenytoin, a common drug-induced liver injury. But probably acute hepatic failure is not the cause in this patient because INR is 1. If the phenytoin lead to acute hepatic failure, I will expect INR to increase. So this patient probably has acute respiratory alkalosis, probably due to head trauma, central cause. What about next step? Next step, we need to know, is it accompanying metabolic acidosis or metabolic alkalosis? We'll look for the bicarb here, 31 millimole per liter. That means you don't need to do the formula. You know, you are intelligent enough to know the bicarb should decrease in respiratory alkalosis, but bicarb here increasing. That means there is accompanying metabolic alkalosis. What is the cause of metabolic alkalosis? How can you pass in metabolic alkalosis in a step-by-step approach? In this patient, as you know, he is taking furosemide, he is taking diuretics because of brain edema, and he probably has vomiting because of these increased intracranial pressures. So these two causes can cause metabolic alkalosis, and you can proceed with serum urine chloride. If you give short course of Lasix and you stop, you will find chloride is low. If there is vomiting, you will find the chloride is low. But if there is ongoing Lasix intake, you will find the chloride in urine is high. Good. You are called to comment on this ABG. What is your diagnosis? pH 7.39, BCO2 75 millimeter mercury, BO2 65, bicarb 41. What is your diagnosis in this ABG? I need to add some points and some rules in this ABG. Rule 1. Bicarb, if it is compensation for, if the increase of bicarb is compensation for respiratory acidosis, it shouldn't be more than 35. That means this bicarb per se 41 denoting metabolic alkalosis. This is rule 1. Rule 2. Compensation, if this is metabolic alkalosis and the BCO2 is increasing as a compensation, compensation never make a normal pH. So if you find normal pH, think about double pathology. It's not compensation. It's very important. Let us see. Bicarb more than 35, it is not compensation, it is metabolic alkalosis. Normal pH means double acid-base imbalance because compensation never be complete. Rule 3, expected BCO2 in this patient equal 0.7 multiplied by bicarb plus 21 plus or minus 2. It is 49.7 plus or minus 2. So it is mixed respiratory acidosis and the metabolic alkalosis and the hypoxia. Remember the next rule because it will be the final rule in this acid-base balance. The most important rule, you are not treating an ABG. You are treating a patient. Always ask about the clinical scenario. For this patient, it could be respiratory acidosis due to COPD, and the patient could have taken a diuretics which lead to metabolic alkalosis and hypoxia due to respiratory due to COPD. This could be a scenario. Another scenario, the patient may have chronic obstructive lung disease or chronic lung disease and corbulmonal and gastric congestion and repeated vomiting leading to metabolic alkalosis. Third scenario, it could be metabolic alkalosis due to mineralocorticoid excess, and this mineralocorticoid excess leading to hypertensive emergency with pulmonary edema and respiratory acidosis. Please, the most important rule while you are dealing with the ABG, you are not treating an ABG. Always ask about the clinical scenario. And most of the way, you find the history is very, very rewarding and very, very important. Like respiratory alkalosis. By knowing the patient has pneumonia and the sudden increase of hypoxia and respiratory rate, that means it is acute. You don't need to do the formula to confirm it is acute or chronic. You can just by history know a lot. To here, I finished 4 lectures about the ABG practical approach. There is remaining 1 lecture about hypoxia in ABG. How can you diagnose all causes of hypoxia by looking at the ABG? It will be a very amazing lecture. Will be the 5th lectures, and to hear with me for another lectures away from the ultrasound. Will concentrate on the ICU in the playlist ICU Academy. I will try to do some lectures without aggressive ultrasound in the lectures. Thank you a lot. See you in another lectures. Bye bye.